We're trying to find the ways to define circulating DNA in T-cell lymphomas. We don't have a standard, or we don't even have good prospective data, like mantle cell lymphoma, for example, or for CLL. We don't have that kind of data. There are a few approaches that are being looked at. So AbbVie is looking at, not AbbVie, sorry, Efimed is looking at, like T-cell receptor, T-cell receptor analysis, their mutation analysis as a possible marker for circulating DNA in peripheral blood. It has been used by Stanford for treating cutaneous T-cell lymphomas, and there's some data from their transplant team to show that they can actually show that the transplant gets rid of these clones in the blood. There are also, there are other approaches to try to look at T-cell receptor degradation or markers of apoptosis in the circulation as part of, it's kind of like a DNA fragmentome as cells are dying. That's very early research. We have no correlative data to support whether that actually indicates disease response or anything. There is a couple of projects going on looking at or trying to establish methods of circulating DNA in patients who undergo an autologous stem cell transplant, for example, to see if the standard right now is you do induction therapy, and then if the patient goes into remission, you take them to transplant, an autologous transplant, to consolidate that remission. But a lot of those patients relapse. So are we missing something here? Is there some way of detecting MRD, for example, in the stem cell collection bag or in the bone marrow prior to the transplant, even though it's negative by flow and cytogenetics and immunohistochemistry? So they're looking at, there are some trials trying to focus on that to try to predict which patients may relapse down the line or not. The biggest problem is getting the right marker. And I think when you talk to these experts who do circulating DNA analyses, is to try to develop the right probe. And it may come down to the fact that you need specific probes for each specific patient. So you need the original tumor, use that to make probes to detect whatever is left of that tumor, the circulating DNA, and then use that to predict response, which is very cumbersome and cost effective. The reason for that is that there are no known specific mutations in T-cell lymphomas that can be followed, like mantle cell, for example, or CLL. So because of that, you may have to individualize probes for each particular patient, which is costly and difficult and timely. So that's one of the bigger challenges.